welcome to the second clinical question time video series. Here at Pharmasimple, we use deep pathophysiology and clinical pharmacology to answer clinical case studies. Now, the theme of this series revolves around the central nervous system, or CNS. Now, kicking off the first episode of the series is a case study involving schizophrenia and antipsychotics. Let's get straight into it. You're a community pharmacist. Mrs. Schizophrenia comes in to have her prescription dispensed. She tells the dispenser that she is very happy since she has stopped hearing voices and hasn't had a relapse with her schizophrenia since upping the dose of olanzapine a few weeks ago. However, recently she started to suffer a noticeable tremor in her left hand and gained a considerable amount of weight. Mrs. Schizophrenia tells you she went to see her GP to give her something for her problems, who prescribed her the following medication. Identify the 2 drug therapy problems present. Now, tremors are essentially involuntary rhythmic muscle contractions and relaxations. Now, beta blockers, like the one on the prescription, are sometimes given to treat tremors. Now, how beta blockers alleviate tremors is not well understood, and it's most likely thought to be due to blockage of these peripheral beta-1 adrenal receptors in the muscle spindles found in the digits of the fingers. Now, some studies support the hypothesis that it actually prevents nerve impulses to the muscles of the fingers. Now, the originating cause for the tremor, whether it's an essential tremor, resting tremor, etc., may be different, and partly why the mechanism of beta blockers are not fully understood. Now, this patient is most likely suffering tremor as a side effect of the antipsychotic they're taking, the olanzapine. Now, this is probably why obviously they've been given the propranolol, the beta blocker. Now, antipsychotics work by inhibiting postsynaptic dopaminergic receptors. Now, specifically, they act on D2 receptors on the postsynapse. So, say for instance, you've got dopamine in the synaptic cleft. Then you've got an antipsychotic which comes along and inhibits that. Whether that's a first or a second generation antipsychotic, or even the third generation, although there's only one out at the moment. Now, second generation antipsychotics such as olanzapine have an additional mechanism of action. Now, this additional mechanism of action is its ability to inhibit serotonergic receptors, also known as 5-HT receptors, and is specifically the 5-HT2 receptor subtypes, of which there are a few subtypes. Note that 5-HT has been seen to inhibit dopamine release from the presynaptic neurons. So, say for instance, you have an interneuron here, contain serotonin. This actually connects onto this presynapse containing vesicles, dopamine. Now, normally, let's say for instance, the dopamine, those vesicles containing dopamine, they actually fuse to the membrane because of calcium influx due to some action potential, and then they release the dopamine into the cleft, which bind to these postsynaptic receptors. Now, serotonin from, say, an interneuron, again goes through the process to release serotonin, can bind onto these presynaptic receptors, which act to prevent the release of dopamine on the presynapse. So because of this relationship, you can see obviously that it's going to have some sort of an effect. Now, there's actually 4 dopaminergic pathways in the brain, and we're just going to touch onto the ones applicable to this case study. Now, first, we're going to talk about an important pathway found in the brain, and that's known as the mesolimbic pathway. So we're going to be looking at dopaminergic pathways. So the first one's known as the mesolimbic pathway. Now, with this pathway, dopamine is normally generated in what's called the ventral tegmental area, which I'll abbreviate as VTA, and it's projected to what's known as the nucleus accumbens. Now, this pathway is often responsible for pleasure and desire, hence it's called the reward pathway. And that's our mesolimbic pathway. Now, you have to know that an overabundance of dopamine in this pathway can actually give what's known as positive symptoms of schizophrenia. Positive symptoms of schizophrenia. Actually, write that in green for you guys in case you can't see that. Positive symptoms of schizophrenia. Now, positive symptoms of schizophrenia is things that are added onto the consciousness that may not necessarily be there. Examples of these sort of symptoms are hallucinations, delusions, so psychosis-like symptoms, as well as flight of speech, or racing topics, so jumping from topic to topic, and illicit substances like cocaine, for instance. They actually stimulate this pathway, and they actually overstimulate the mesolimbic pathway, and this gives this euphoria, and it's this euphoric effect that can create a perpetual cycle for addicts to take more, and explain some of the symptoms cocaine addicts actually suffer. And it's a constant cycle. So that's something for you to take note of. Now, reducing dopamine in this area as a result can actually alleviate some of the symptoms that we see with patients suffering from schizophrenia. And that makes sense. And so you may not get some of these psychosis-like symptoms. And that can be done by blocking those D2 receptors found on the presynapse. And we can do that using, for instance, antipsychotics. And that actually explains why, Mrs. Schizophrenia is saying that it's alleviating her auditory hallucinations, and why she's so happy about that. Now, auditory hallucinations, they tend to be the most common type of hallucinations seen in these type of patients. Now, you have to be careful because drugs don't just work on a single dopaminergic pathway, as they spread to all areas of the brain when they cross that blood-brain barrier. And this includes another pathway known as the nigrostriatal pathway. Now, the nigrostriatal pathway projects dopamine from a place called the substantia nigra to an area of the brain known as the striatum. Now, obviously, this nigrostriatal pathway, it's sometimes actually known as the movement center. And you can probably guess that it's going to affect motor function. So it's known as the movement center. Now, inhibition of dopamine in this area therefore is going to result in movement disorders. And examples of movement disorders can be Parkinsonian-like symptoms or even Parkinson's disease. And this can be predicated by excessive nigrostriatal acetylcholine transmission, since dopaminergic neurons have these postsynaptic connections with cholinergic neurons. And you need to remember acetylcholine is actually involved in muscle contraction and relaxation. So visually looking at it, what happens is you have, say for instance, so there's actually an inverse relationship between, again, dopamine, but this time acetylcholine. Obviously that's going to mean decrease in dopamine causes increase in acetylcholine. So say for example this is an or a cholinergic neuron. Any release in dopamine is going to cause, an effect on acetylcholine transmission. And so a decrease in dopamine is going to cause an excessive increase in acetylcholine. Now, this can actually explain the tremors that Mrs. Schizophrenia is actually suffering, because remember, these antipsychotics, they're going to cause a decrease in dopamine because they're blocking those postsynaptic D2 receptors on which a biological response is being elicited. So that means you're going to get this excessive acetylcholine release, and that means that obviously because acetylcholine has an effect on muscle contraction and relaxation, you're going to get these movement disorders as a side effect, and these are known as extrapyramidal side effects, or EPSE. Now this is actually our first drug therapy problem, and it should be flagged to the prescriber. So if we look at the prescription itself, we can actually tell because she's been given the propranolol for tremors and she's taking an antipsychotic. And when did she actually say that she started suffering from these tremors? Recently she started noticing, getting a noticeable tremor in her left hand, and she upped the dose of the olanzapine a few weeks ago. So it might have been from the increase in antipsychotics that she started getting these tremors, and thus she's been giving a beta blocker to help alleviate that. Now there's different options that may be discussed, such as, reducing the dose. But you have to be careful. This may not, control her condition, because remember, reducing the dose may cause Mrs. Schizophrenia's symptoms to come back. That's something to take into account. Now, another thing that you could try doing is giving her is an anticholinergic. Now, based on the pathophysiology and pharmacology, we know that there's an inverse relationship between dopamine and acetylcholine. So obviously we know that reducing dopamine gives an excessive release of acetylcholine. So that means if we actually cause reduction in acetylcholine using an anticholinergic, we should actually get an increase in dopamine. And hopefully in that nigrostriatal pathway, obviously if we cause an increase in dopamine, hopefully that should alleviate those movement disorders and those tremors that she's getting. an example of an anticholinergic that can be given. There's a few that are actually given, but one common one is procyclidine. Now, although second generation antipsychotics have a lower instance of extrapyramidal side effects due to a more rapid dissociation from D2 receptors, because obviously olanzapine is actually a second generation antipsychotic. A third generation antipsychotic like aripiprazole is actually a partial agonist, and partial agonist gives, well, as a general rule of thumb, 50% efficacy at 100% receptor occupancy, and that's something that might be tried. But there's other options, and this should be addressed with the prescriber. Now, with the first drug therapy problem identified, let's move on to the next issue. So, the second drug therapy problem is the patient suffering from weight gain. So, she actually said to us recently she's gained a considerable amount of weight. And obviously we don't know for a fact it may be a drug, but if you actually look carefully, we can tell it probably is. Now, antipsychotics in general cause drowsiness. Now, with most CNS style drugs, because they cross the blood-brain barrier, it can cause drowsiness. But antipsychotics actually block H1 receptor subtype, and that can cause quite significant drowsiness because they cross the blood-brain barrier. In this case, this antipsychotic, this may make patients want to walk around less, and so obviously they're going to burn less calories. Now, that's with all antipsychotics, including first generation antipsychotics. However, second generation antipsychotics actually have an additional mechanism which makes the patient at an increased risk of weight, and that's by blocking the 5-HT2C receptor subtype. Now, what that does is it actually increases appetite, and you can actually question Mrs. Schizophrenia on that, but both of these, it's going to double her risk. Now, note that olanzapine actually has one of the highest affinity for the H1 receptor subtype out of nearly all antipsychotics, so that doesn't help either. And so it's actually one of the most likely to cause weight gain. So it's one of the most likely antipsychotics out of all the ones that exist. Now, it may be prudent to bring this up with the prescriber. Schizophrenia patients in general are actually at greater risk of diabetes, and increasing weight may actually put a patient at a greater risk of hyperglycemia and type 2 diabetes. Now, this is why patients on antipsychotics actually have their cardiovascular risk checked, blood sugar and lipids all monitored, because they're at such a high chance of getting other comorbidities, and it's something that we need to monitor both in primary care and as a general clinician. Now, with both drug therapy problems identified, let's move on to the patient query portion. While sorting out her DTPs or drug therapy problems, Mrs. Schizophrenia asked if she could have a quick word. She tells you she has noticed her periods have become somewhat irregular and was hoping you could give her some advice. So, this is probably due to actually an hormonal imbalance caused by olanzapine. And, we should anyway, just in case, just check her sexual history, just, because some people might think, is there a chance she's pregnant, and, just backtrack and double check. But there's actually a third dopaminergic pathway in the brain, and this is known as the tubero-infundibular pathway. Now, this is actually nicknamed the hormonal pathway, and you'll probably be able to figure out why in a second. Now, this pathway involves the hypothalamus, an area of the brain controlling homeostasis based on positive and negative feedback mechanisms, and the pituitary gland. Now, normally an abundance of dopamine here acts to inhibit the secretion of a hormone known as prolactin. Now, prolactin is commonly known for its effect on the female reproductive cycle, amongst 300 other processes affecting metabolic state, osmoregulation, immunoregulation, and behavioral function. But prolactin was actually named after discovering its effect on promoting milk production or lactation, hence prolactin. Now, antipsychotics like olanzapine, we know, reduce dopamine. Now, we see reducing dopamine is actually going to increase prolactin. What does that mean? We're going to get more of these effects. Now, because of this inverse relationship, this actually explains the menstrual irregularities being experienced on my Mrs. Schizophrenia, and this could actually be brought up with the prescriber. Now, aripiprazole, which is a partial agonist, acts as an antagonist in the presence of a full agonist, such as endogenous dopamine, as endogenous dopamine has a greater affinity compared to aripiprazole. However, even at 100% occupancy, only causes 50% biological activation as well. So there's actually a reduced risk of hyperprolactinemia compared to second-generation antipsychotics, like olanzapine. This is just one option among many that could be discussed with the prescriber. Now, that concludes today's case study. I hope you found it useful. Don't forget to subscribe, like, and share, and I'll see you next time.